I welcome you all to yet another edition of the Kunle Hassan Eye Foundation Academy Retina series. This is the 9th lecture in the series. My name is Frances and I'll be taking us through the introduction and a brief of our house rules. Today we'll be looking at the topic B-scan ultrasonography for the posterior segment. The program flow, currently I'm doing the welcome and introduction. Afterwards, we'll listen to the presentation from the speaker. Then we'll have the interactive session and the closing remarks. Briefly about the Kunle Hassan Eye Foundation Academy. It is a member of the Eye Foundation Eye Care System that anchors the training for different cadres of professional in ophthalmic field. And the Retina series started in 2023, and this is currently the 9th lecture. Today, our presenter, Professor Basi Fibai, would be sharing with us her experience. A brief profile about our speaker. Professor Basi Fibai is a vitreoretina specialist and consultant ophthalmic surgeon with the Department of Ophthalmology, University of Port Harcourt Teaching Hospital. She is also a professor of ophthalmology in the University of Port Harcourt. Professor Basi is a fellow of the National Postgraduate Medical College of Nigeria, where she currently serves as an external examiner. She is also a fellow of the International College of Surgeons and has a fellowship in medical retina from the prestigious L.B. Prasad Eye Institute in India. Professor Basi is the current national chairman of the Vitreoretinal Society of Nigeria and the immediate past head of departments in both the University of Port Harcourt and the University of Port Harcourt Teaching Hospital. She has written over 60 publications in local and international journals and serves as an associate editor in many professional journals. She is married with 3 sons. I would hand over the floor to Professor Basi, where she'll be speaking on B-scan ultrasonography for the posterior segments. Thank you all for joining.
Good morning, everyone. I hope you can hear me.
Yes, we can.
Okay, I'm trying to share my slide. Great. So good morning again, everyone. I want to thank you all for finding time to join this lecture series. I hope you can still hear me and you can see my slide.
Yes, we can.
Okay, great. So let me start by thanking the organizers of this lecture series, Dr. Kunle Hassan, our father in the retina space, who is also a member of the Board of Trustees of the Vitreoretinal Society of Nigeria. Let me also appreciate the Kunle Hassan Eye Foundation Academy for inviting me to speak at this series. I want to also appreciate Dr. Derinlo and his team, who have ensured that this series continues. And also special thanks to Frances, the engine room of this series. I will also especially like to appreciate members of my department, my senior colleagues and colleagues who have rescheduled their morning weekly clinical meeting so that they can be part of this lecture series. I appreciate you all. So I have no financial disclosures. Very quickly, I have just 45 minutes to make this presentation. Ultrasonography is actually a very vast topic, but today we will be looking at just B-scan mode of ultrasonography for the posterior segment, obviously because this is a vitreoretina series of lectures. Ultrasonography is also called echography, and it's a painless, non-invasive imaging technique that uses reflections from high-frequency sound waves to construct an image of the body or a body organ, in this case the eye, also known as an echogram. It's one of my favorite investigational tools, actually, apart from OCT, because it's able to give you instant information and real-time feedback. So in your clinic there, You have your ultrasound scan machine. You're trying to make a diagnosis. It can give you the information you need to wrap up your diagnosis and institute management just right there and then. So it helps to evaluate structures of the eyes and its surrounding, and it's very good in the diagnosis, measurements, and monitoring of ocular pathology. So very briefly, let's just look at the history. The earliest reported application of ultrasound scan was by Mont and Hughes in 1956, where they described the use of pulsed echo A scans in the detection of intraocular tumors. And then in 1958, Baum and Greenwood developed the very first B scan using the immersion technique for ophthalmic use. Osnig and his colleagues in 1960 were the ones that first introduced the concept of standardized echography, which we'll be appreciating later because that's the best form of doing an ultrasound scan and interpreting an ultrasound scan, standardized echography. But it was Nathaniel Bronson that first developed the handheld contact B scan that we are all now enjoying, the portable handheld contact B scan. So why and when do we do ultrasound scans? There are three indications for that: in opaque ocular media, in clear media, and of course for follow-up studies. So in opaque ocular media, when you have anterior segment pathology that precludes your visualization of the posterior segment, for instance, if you have corneal opacities, blood in the anterior chamber, hypopyon, pupillary membranes that prevent you from dilating the pupil to access the posterior segment, and of course in dense cataracts. Also, if you have vitreous hemorrhage and severe inflammation and you're unable to assess the retina and the vitreous, you would want to do an ultrasound scan. You can also do it when you have clear media, so it's just not in the case of opaque media. If you want to study iris tumors and ciliary body lesions, but these are best done with the immersion technique. It's also used to help detect and differentiate tumors and masses, and we will see that when we start to look at the individual ocular pathology. Also to study retinal detachment, if it's tractional, if it's exudative, and to detect and localize intraocular foreign bodies, and of course study optic disc abnormalities. We're all familiar with its use in biometry, but it's also very useful when you started instituting some form of its intervention when you're managing tumors, to measure it and then, subsequently follow up to see the progress of your intervention. Same thing for vitreous hemorrhage and inflammation. You can use it, you can do serial B scans, to follow up the patients to see if the hemorrhage or inflammation is resolving and decide if you want to change your management strategy. But to be able to carry out a good ultrasound scan and interpret it, even when it's sent to you, you need to understand some basic principles and physics of ultrasound scan, of ultrasonography. Ultrasound is an acoustic wave that consists of oscillating particles and has a frequency of greater than 20 kilohertz. So the audible range of the human ear is able to hear sound between 20 and 20 kilohertz. Any frequency greater than 20 kilohertz renders these sounds inaudible to the human ear. So the key principles to understand: the wavelength of an ultrasound scan determines the depth of tissue penetration and resolution. I'll take that again. The wavelength of an ultrasound scan determines the depth of tissue penetration and resolution. It's important that we understand this because we will see why abdominal scans don't have quite as good a resolution as the ocular scans. So when frequency increases, wavelength automatically decreases. So if you have large frequency, the wavelength will be shorter, your depth of penetration will be reduced, and your resolution will be better. So resolution is better when there's reduced depth of penetration from larger frequencies and shorter wavelengths. That's why the ophthalmic probes have a larger frequency than the abdominal probes. So the typical ophthalmic probes, the frequency is about 8 to 12 megahertz for the A and the B scan. But for ultra biomicroscopy, we have up to 50 megahertz. So abdominal ultrasound scans 1 to 5 megahertz, the probe frequency. For ophthalmic probes is 8 to 12, and then all ultrasound valve microscopy 20 to 50 megahertz. That's the one that is used for the anterior chamber to be able to appreciate the anterior chamber structures very clearly. The resolution is extremely high, and it's taken over the use of immersion techniques. So certain terminologies that we also need to understand in physics of ultrasound scan: velocity, relativity, angle of incidence, and absorption. Velocity is simply the distance that is covered by an object in a unit time. So you find out that the sound travels faster in solid media than in liquid. So you have the velocity, for instance, in the vitreous being less than that in the cornea or in the lens. What is an echo? It's important that we understand what an echo is, because ultrasound scan is all about echoes, just the same way that OCT has to do with light. So ultrasound scan is sort of analogous to the OCT. So in ultrasound, we talk about echoes: hyperechoic, anechoic, or hypoechoic. And an echo is simply the part of the reflected sound that comes from the probe when sound hits a medium. So the part of the reflected sound to the probe when it travels from one medium to another of a different density. So when sound travels and hits a media, there's some reflection of the sound, and the reflected sound depends on the density of the media. So if the medium is less dense, there will be less reflection and the echo will be weak. For instance, the echo in the vitreous is weak because the media, because it's not as dense as what you would have, for instance, in the lens. Again, if the medium is dense, it's quite dense, you will have a strong echo because you will have greater reflection. The angle of incidence also affects the type of echo that you get on ultrasound scan. If your probe is placed perpendicular, then you have a stronger echo. If it is placed obliquely, then the echoes that you will get will be weaker. Absorption is another property that can affect the echo, the strength of your echo. Sound is absorbed by every medium it passes through. The amount of absorption is directly proportional to the density of the medium. So a dense cataract obviously will absorb more than the normal lens. So orienting the probe on the sclera rather than the cornea gives a better image, because by so doing, you're bypassing the lens. And also, if you have calcification in a tissue, the absorption will be more and your echo will be stronger. When you have the absence of an echo, if you have a calcification, for instance, behind that medium, there's something referred to as shadowing. So what is gain? Gain is a process of increasing or decreasing the amplitude of the displayed echoes on the screen, and is measured in decibels. So you can decrease the gain if you want to study tissues like your retina that have very high reflections. And if you want to study the vitreous that has weak echoes, you have to use a very high gain. So, but the rule of the thumb for every scan is to start with a high gain so that you don't miss any of the weak echoes that comes from pathologies in the vitreous. So you reduce the gain gradually as necessary for a better resolution of stronger echoes. So there are different types of scan, but we'll be focusing mainly on the B scan and a bit of the A scan, because you need to understand the A scan to be able to interpret the B scan better in what we call standardized echography. So what instruments do you need to have? The ultrasound scan machine is a very simple now very portable equipment. It has a monitor where the echogram is displayed, and it has the probe. It's best to get the system that has both the A-scan probe and the B-scan probe. If you get the system that has the B-scan probe only, just make sure that you can access the A-scan vector on it, because the A-scan vector needs to be superimposed over your B-scan echogram for you to be able to interpret your echogram properly. It also has a foot pedal that is used to capture the images as you scan, and of course the keyboard where you input the profile of the patient that you're scanning. Just to note that the probe is the most important part of this instrument. If anything happens to the probe, that's the end of the, and it's very expensive. That's the end of the machine. So how does this work? It's a case of electrical energy being converted to sound energy being converted back to electrical energy. So what happens is when you put on your scan, an electrical pulse is generated and an oscillatory signal. So you will feel your probe vibrating. That's the oscillation that is in the probe. And this oscillations is as a result of the piezoelectric crystal that is in the transducer of the probe. So this piezoelectric crystal is stimulated in the probe, and sound waves are projected onto the ocular tissue. Some of it is now reflected back into the transducer as the echo. And this goes into an amplifying system, a receiver system that amplifies that echo and produces a two-dimensional image on the monitor, which is called the echogram. So this is the echogram, and this is the amplifier, which is in the probe as well. So this is what the A-scan looks like. It's a one-dimensional acoustic display. So it's one-dimensional. All the spikes arise from this plane. You have 5 vertical spikes that arise from this plane, from a baseline. The stronger the echo, the higher the spike. So that's why it's called amplitude mode. A stands for amplitude mode, because the stronger the echo, the higher the spikes. And it is the height of these spikes or the amplitude of these spikes that you look at that tell you about the character of the lesion or the pathology that you're trying to study. A typical frequency for the A-scan is an 8 megahertz probe. So the frequency for the probe for A-scan is 8 megahertz. So this is what the 5 spikes look like. If you look at it, you'll see 5 equal spikes, one for the probe, the cornea, the anterior surface of the lens, the posterior, and then the retina choroid scleral spike comes as a complex. And then this reduced spikes behind the sclera are for the orbital spikes. So what do we use A-scan for? Measurement of axial length, and most importantly as well for this presentation, in combination with the B-scan to make a diagnosis. So it will tell you of the character of the tumor. It can tell you of the character of a lesion, the internal structure of a lesion. So for instance, if you're looking at a tumor, you want to know if it is homogeneous or if it is heterogeneous in consistency. If it is homogeneous, you will see uniform spikes. If it is heterogeneous, you will see irregular spikes, some high spikes and some low spikes. So that may tell you that either there is a calcification in that tumor, or there is maybe like in choroidal metastasis, you know, it just tells you that the internal structure is not quite, the echographic interface is not very homogeneous. Also, the A-scan spike can also show little vascular pulsations on kinetic ultrasound scan that will indicate that you're dealing with a vascular structure, for instance, in choroidal melanoma. B-scan stands for brightness mode, and this is a two-dimensional acoustic session. You know, the A-scan was a one-dimensional one. This is a two-dimensional acoustic session. It's section is displayed in both vertical and horizontal dimensions on the screen. The echoes are represented as dots on the screen. So that's why you see this, bright dots here. So for structures that are very reflective, you refer to them as hyperechoic, because the brightness, the dots from it is very bright, and it means that the strength from that echo is very strong. So when you have multiple dots coalesce, it gives you the two-dimensional structure that you see in B-scan. So B-scan stands for brightness mode, and unlike A-scan, where the amplitude of the spikes tell you about the strength of the echo that is coming from the tissue, for B-scan, the strength of the echo is depicted by the brightness of the dot. So when you have high amplitude echoes, it appears white, and you refer to the echoes from that structure as being hyperechoic. When it's low, it's hypoechoic. If there are no echoes, it's echolucent or anechoic, and the probe frequency for the B-scan is 10 to 12 megahertz. So to be able to interpret pathologies in the posterior segment on an echogram, we need to understand what the normal pattern looks like. So the lens is the first major structure that you see, and it is a highly reflective structure at curvilinear. I'm going to find my cursor. That is curvilinear after that of the probe. Then you have the anechoic or echolucent vitreous chamber that is circular in shape. Then the retina, choroid, and sclera appear as a single complex, a single structure, which is highly reflective. The sclera actually has the highest spike, and it's about 100%. So every other spike that you see on the A scan is described in relation to the scleral spike. You also have the optic nerve that appears as an anechoic structure. So the optic disc is the area at the anterior portion of the nerve here, and the macula is seen temporal, especially on axial horizontal scan, is seen temporal to the optic nerve. The orbit is highly reflective, is a highly reflective portion here, posterior to the sclera, and this is due to the orbital fat. You can also see the extraocular muscles, which appear as fusiform or linear shaped structures. So standardized echography is the best way to report or study your echogram. So the optimal echographic examination results from the appropriate combination of both modalities, that's the A scan and the B scan. So when you see an echogram, you must quickly look for the A scan vector, or the A scan spike that has been superimposed on the B scan one, so that you can interpret your pathology well. So if you look at this interface, you will see that there is no spike here. It is silent, and that stands for the vitreous here in this aspect. Here there's a bit of hemorrhage, so there's a high spike here. I would say about medium reflectivity. Here there's a tractional detachment here, so you can see that the spikes are very high, almost to the level of the scleral spike, very high spikes. So if you don't have this A scan superimposed on it, it will be difficult for you to make out. For instance, if you have a membrane, you want to know if it's a posterior vitreous detachment or a retinal detachment. The A scan spike will help you to assess that better. So the A scan helps and talks about the lesion, the character of the lesion, like I said, and while the B scan gives us information on the topography. That's the shape of the lesion, the location, the lateral extent. So before any examination, the echographer should inform pertinent history and clinical findings. It's difficult to do a scan when you don't have clinical findings, because you must always relate the clinical information with your scan. Like it said severally, you don't treat lab investigations, you treat the patient as a whole. So you must have a good history of the clinical, a good history and clinical findings, and tie everything together to be able to make a diagnosis and institute your management. Also remember to explain that the procedure is not painful and reassure the patient. Always ensure that you scan both eyes so that you can compare, and be very careful with the probe because it's the most important part and it's very delicate. So typically, the echographer, whoever is doing the scan, should stand to the right of the patient and ensure that you can simultaneously see your monitor at the same time as you're scanning, okay? And then, that's your foot pedal that you use to capture your images. So it's very important to understand the orientation of the probe is the most important part. The probe is usually placed gently over a closed lid, but what is best is if you can place it directly on the cornea, though this is very uncomfortable, but most people scan patients over the closed lid. But if you're doing it directly, you must anesthetize the eye. And if you're using if the patient's eyelid is closed, you have to apply a coupling agent to get rid of the air interface, because there will be attenuation of the sound waves. The marker on the probe is very important because it will represent the side of the probe on the echogram. So for instance, if you're placing this marker, which is usually represented by a line or a dot, some companies may put their logo. So the first thing you do when you handle a probe is to identify where the marker is. So if you place this, for instance, facing the nasal aspect, then it will be the nasal portion that you're seeing in this superior aspect of your echogram. So the probe face is represented to the left of the echogram, while the right side of the echogram shows the opposite side here. So you use different examination techniques to get the type of information that you want. So you first, to get information on the topography of a lesion, that's to evaluate the shape, where it's located, the extension, either the lateral or anterior posterior extension. You have to employ both your A and your B scan to be able to achieve that. For quantitative evaluation, you're looking at the reflectivity of the A scan spike. That's what you want to really focus on. So the A scan is more useful for quantitative assessment. It will also tell you about the structure, the internal architecture, like I said, of the structure, because you will see the heights of the spike. Either it's reduced or it is high, and it will give you the information that you want. Also, for kinetic examination, this gives you an idea of the mobility, for instance, of a membrane. So if you have a posterior vitreous detachment, you're expecting to see an after movement. When the eye moves and then becomes stationary, you will see an after movement. If the membrane is very mobile, then you know you're dealing with something like a posterior vitreous detachment. Also, when the eye is stationary and the probe is stationary, if you see little pulsations on the A scan, then you're probably dealing, and there is a mass that you're trying to study, then you're probably dealing with a tumor that's or a lesion that is vascular, because you'll see the pulsations, on the A scan. So like I said, the sclera is the normal, is the structure, the ocular structure that has the highest spike, and that spike is 80 to 100%. In fact, it's 100%. So every other spike that you're trying to evaluate, you should compare it to the scleral spike. So for medium spikes, it may be about 40 to 60% of the scleral spike. For very low echoes, you may have, between 5 and 40, or 0 and 5. And then for low ones, between 5 and 40. So you're looking at the strength of the echo by looking at the A scan spike to know how reflective that tissue is. So there are different probe orientations that we use in carrying out ultrasound scan. But the major ones are axial, transverse, and longitudinal. Usually the axial and the transverse scans are what is mostly done. You use the longitudinal scan if you identify a lesion that you really want to study. So the axial scan, you can do it in both the horizontal and vertical positions. The transverse scan is scanning superior, inferior, nasal, and temporal quadrants, and it scans 6 clock hours at a time, while the longitudinal scan can only scan like 1 clock hour. So that tells you, usually you use it when you want to study the anterior-posterior extent of a lesion, maybe a tumor or a mass. So how do you do an axial scan? The probe is positioned between the 3 and 9 o'clock position, like here. So this is a horizontal axial scan. The marker is important because it's pointing, when you're doing your horizontal scan, the marker points nasally, and that means that you will see that portion on the top part of your echogram. So the nasal part of the retina appears on the top part of the echogram, and the optic nerve is usually used as a reference point. So when you're doing your axial orientation, it passes through the lens and the optic nerve. So it helps in determining the position of a lesion in relation to the optic nerve. So you can relate whatever lesion that you see to the optic nerve. Is it below the optic nerve? Is it above the optic nerve? You know. You can also do this in the vertical orientation as well, where this probe marker is now oriented vertically. So this probe marker will now be oriented vertically. That is the vertical axial scan. So the transverse scan, the probe position is inferior. You could add, if you're studying the superior retina, you position the probe inferiorly and ask the patients to look superiorly. The marker will typically be pointing towards the nose. So for inferior and superior probe orientation, the marker points towards the nose. So if you're scanning the inferior portion of the retina, the patient will look down and your probe will be placed superiorly, but the marker will point nasally. If you're scanning the nasal and temporal retina, the marker should point in the 12 o'clock direction, and the patient will be looking in the opposite direction to the area that you want to scan. So this is the transverse orientation. You can see the marker is facing the nasal aspect, but you're scanning the superior retina. So the probe is on the inferior aspect, and it scans up to 6 clock hours. Same thing here. If you want to scan the temporal aspect, the patient looks outwards. Your marker should face superiorly, and it will scan 6 clock hours there. So for the longitudinal scan, the probe will be placed perpendicular, and this can only scan 1 clock hour, but it's good when you're trying to study the extent of a tumor or a tear. So the important thing to note is that the axial scan is usually done in the primary position of gaze. The echoes are weaker because of the absorption of the lens. So you get better echoes when you do, you get stronger echoes when you bypass the lens in the transscleral orientations. So for the transverse and longitudinal scans, you will have stronger echoes because you're bypassing the lens. So now let's go straight to, because I know that the time is almost up, so we want to now look specifically at ocular pathology. So there are 3 main types of echo textures that you see on B-scan. So you either describe the texture as a dot-like lesion, which is what you see in hemorrhage. You can see these bright dot-like lesions with low to medium spikes, amplitude of spikes on the A-scan. So you describe this as dot-like lesions. So you want to say, oh, there's a medium echo hyperechoic dot-like lesion, or there are homogeneous hyperechoic dot-like lesions in the vitreous cavity. That's how you would describe this. You could also have membranous opacities. Though there's no A scan over this, but if there was an A scan, what you'll be looking at is the height of the spike. Is the spike low? Is it medium? Is it high? You will also want to check if it is attached to the optic nerve. So you can have membranous opacities in cases of PVD, retinal detachment, and what will help you differentiate it is the height of the spike and other features like attachments to the optic nerve. The other echo texture that is commonly seen are mass-like lesions. So you can see this is a mass-like lesion, and this also you can study it using the A scan to see the nature of the spikes, the strength or the amplitude of the spike over this area. So the first we'll look at is asteroid hyalosis. This is actually a very striking picture, and once you see it, it's not easy to miss because you have very hyperechoic dots in the vitreous cavity with high intensity spikes. That's the amplitude will be really high. The amplitude of the spikes will be high. But what is striking is this very clear zone of echolucency here, which will differentiate it from maybe a vitreous hemorrhage that may probably be throughout, that you would see, throughout the vitreous. So there's a clear vitreous zone between the posterior boundary and the posterior hyaloid. So this is a patient, a 72-year-old woman that I managed that has asteroid hyalosis. So even though here you can see the clear zone, but that's why clinical information is very important, because she also has a vitreomacular adhesion. So if you look here, you will see this high spike that corresponds to this vitreomacular adhesion. So she has two pathologies here, and possibly even three, maybe old vitreous hemorrhage as well. So the clinical information is always very important. So here you can differentiate between a fresh vitreous hemorrhage, where you see this homogeneous, and you can see that the spikes are the same. It's homogeneous, low to medium intensity spikes. Compared to the old vitreous hemorrhage, there's no A scan over it here, but this will give you higher spikes, and you can see that the intensity is more hyperechoic than what you have with the fresh vitreous hemorrhage. Now, sometimes it can be very confusing, when you want to differentiate between an endophthalmitis and a vitreous hemorrhage, and that's why also clinical information is very important. So these are two different patients, but you could easily confuse this with a vitreous hemorrhage. But this patient had intravitreal Eylea and ended up with endophthalmitis, strictly patient-related issues. It had nothing to do with the injection. So we were able to use B-scan to also follow up we started her on very aggressive intravitreal antibiotics and peribulbar steroids, and she did very well. But look at how uniformly distributed this vitreous hemorrhage is, But this, you can actually confuse the two. You could actually think that this is vitreous hemorrhage as well. So clinical information is very important. So ultrasound scan, like we said, is very important for follow-up studies. This was the same patient, and this was her, after treatment, and her vision went from hand movement to 6 now. In fact, now it's 6/5. So it's very useful for following up your patients, doing serial scans to follow them up. This is a picture of an echogram of a dropped nucleus. It's very classic. You would describe this as a hyperechoic mass in the vitreous, and the intensity of the spikes, if there were to be an A scan spike over it, you will see very high spikes. And you're also able to appreciate the location. This is sitting pretty on top of the optic nerve head. This is the anechoic optic nerve. You can see that the echo strength here is much, much brighter than what you have here. So posterior vitreous detachment is another very common condition that we see. It could either be still attached to the optic nerve or completely detached from the optic nerve. But the membrane is usually freely mobile and you have an after movement on kinetic examination. So the reflectivity is what helps you differentiate. It's one of the things that help you differentiate between this and a retinal detachment, because the reflectivity for the posterior vitreous detachment is usually low. It's not a very high, it's low to medium reflectivity. And if there is a vice ring, you will actually see it in the vitreous, and you will see that the reflectivity of that vice ring, because it's part of the retina that was done, will be high. So this was a patient I had, a 54-year-old patient that came in complaining of seeing a black line and all that. And when we did the scan, if you look at the spike here, you'll see that is low to medium. You know, some people may confuse this with a retinal detachment. If it was a retinal detachment, the spike would be higher, but this is the spike for this membranous opacity that is hyperechoic, and it was detached from the optic nerve, so that could also confuse you. But this is a complete PVD because it was not attached. This is the optic nerve. It wasn't attached to the optic nerve. So retinal detachment, the membranes, you also have a hyperechoic membrane in retinal detachment. But the characteristic thing is that the movement is restricted, very little or no movement, as compared with posterior vitreous detachment that is very, very freely mobile, and it's always attached to the optic nerve. So you want to do your scan and ensure that the picture that you're sending out has the relationship to the optic nerve, has the attachment to the optic nerve, so that the clinician or whoever it is that is looking at it, you know, can appreciate that it's a retinal detachment. Or if you're doing it yourself, you want to quickly ensure that you look for the optic nerve and see if it is attached, you know, to the optic nerve. Here, there's even a bit of subretinal fluid in the subtenon space. There's some fluid there, if you notice. So here you have a tractional retinal detachment. Usually, it's described as tabletop or tent-like. You know, so you have a tractional retinal detachment there, and usually this has hardly any movement. So choroidal detachment is another membranous opacity that you see on an echogram. It could either be serous. You can see this is a clear fluid space. It's a serous choroidal detachment, but this is a hemorrhagic detachment. So this is what you call kissing choroids. It typically arises from the periphery. That's how you distinguish it from retinal detachment. So choroidal detachments are not attached to the optic nerve. It's a smooth dome-shaped membranous opacity that comes from the periphery. So when the two meet, like this, is referred to as kissing choroids. It's also the A-scan spike shows you a double spike, also referred to as the M spike, which is representative of the retina and choroid. So for the choroidal detachment, you will not see any attachment to the optic nerve. So how do you differentiate between the three? Because it's usually very confusing. Topographically, PVD, retinal detachment, are V in shape. Retinal detachment may be linear, but the choroid will always be dome-shaped. The location will vary in PVD and retina, but the choroid is usually pre-equatorial. There's always an attachment with the retinal detachment. There may or may not be in PVD if it's complete or incomplete, but in CD there's no attachment. Now the height of the spike, the amplitude of the echo for PVD, low to medium. For retinal detachment, very high. For choroidal detachment, very high. You have a double spike, like I said. The kinetic mobility is very marked in PVD, is moderate to restricted, and then in choroidal detachment is very marked. So this is a mass-like lesion. This is a choroidal melanoma and is a mass-like lesion. So the characteristic thing on sonography for a choroidal melanoma is that, first of all, it has this collar-stud appearance or mushroom-shaped appearance. And then you will see choroidal excavation here. And behind it, there is an acoustically silent zone, behind. Also, if you look at the A scan of it on kinetic examination, you will notice some oscillations when both the probe and the eye are stationary. Retinoblastoma is another mass-like lesion that is dome-shaped. Here you can see the intralesional calcification, so you see that the spikes are very high. Posterior scleritis also has a very striking appearance. You can see that the scleral complex is very thickened, and there is Tennant's fluid here in the Tennant space. This is your optic nerve, so it gives it a T sign, with the leg of the T being the optic nerve. And I think the last one we have is the optic disc drusen, where you have a hyper-echoic lesion here that persists on low gain. So even when you reduce your gain to the minimum, you will still see the echoes persist. So in conclusion, B-mode ultrasonography still provides valuable quantitative and diagnostic information of the posterior segment. For me, I would recommend it as first imaging modality of choice, especially in our environments because of the reduced cost. And it's important to always interpret the B scan with the corresponding A scan to give you the accurate information that you require. Always remember that you must correlate your clinical findings with the scan to be able to arrive at a diagnosis and treat the patient appropriately. So I hope I have been able to demystify ultrasonography and make it more interesting and appealing as a modality of choice. Thank you.
Thank you very much, Ma, for this very insightful lecture. We appreciate you for honoring our invitation. So we open the floor to questions. So if you have any questions for us, you can either raise up your hand or you post your questions in the comment section. Thank you. Any questions, comments, or contributions? I have Dr. Maria's hand is up. Dr. Maria, please unmute your mic and ask your question.
Good morning, Professor Febai, and good morning, everybody. That's a very good presentation, quite detailed. I want to ask if you can explain more on the placement of the B-scan probe, talking of the axial and the longitudinal. What's the difference? Because the positioning is almost, to me, is almost the same as vertical. Longitudinal is like vertical. Axial is also like vertical. So what's the main difference?
I'm trying to see if I can share my slide again to be able to explain it. Can you hear me, please?
I can hear you very well.
Okay. So you want to know the difference between the axial and the
longitudinal? Yes.
Okay. So the axial, first of all, the longitudinal, the orientation of the marker, the orientation of the probe is perpendicular to the globe, and you bypass, you don't put it on the cornea. You put it is transscleral. Do you get that?
Yes.
While the axial, you center it on the cornea. The patient is looking in the primary gaze of position. So you put it on the, well, over the closed eyelid, but you know, you're putting it directly in front of the patient. You're not bypassing the lens. I don't know if you understand that.
Yes, because you mentioned placing the axial on the cornea. I do the probe with the B-scan with the eyes closed, with the
Yes,
closed
with
lid.
the eyes closed. That's what I mean, with the closed lid, yes. With the closed lid, you're putting your probe in the axial one, in the primary position of gaze, right over the closed lid. Do you understand? The patient is looking in the, yes. But with the longitudinal, you're putting it perpendicular, you know, like to the limbus, to bypass the lens. You know that when you do an axial scan, you know, the lens is going to absorb some of the echoes and all that. So you're not going to get as strong an echo and resolution as you will get if you bypass the lens.
The lens, okay.
You understand?
I do, yeah.
Oh, okay. Any other question?
Thank you.
Hello.
Hello, Dr. David. Please unmute your mic. Your hand is up. Can you unmute your mic and ask your question, Dr. David?
Good morning, man. My question is with the gain. I would want to know if there's the gain.
Okay,
The gain, yes, on the B mode ultrasound.
yes.
So is there a baseline level that we should keep it that we can now say this is increased gain or reduced gain? And then if you are doing a scan, if you are doing a scan for a condition like retinoblastoma, how do you know that this is a calcific lesion? How much hyperechoic opacity do you need to see to know that this is a calcific lesion? Thank you.
Okay, so the gain actually depends on the machine, okay? But most times between 80 to 100 is high gain enough for you to be able to pick your weak echoes. 80 to 100 decibels. You have, you know, you can pick your weak echoes with decibels of 80 to 100, and then you now start to reduce it to be able to study lesions with lower echo strengths, like retinal detachments. Do you understand that? So best to start with the high one so that you don't miss any weak echoes in the vitreous. Then you start to reduce the gain, because the gain is actually the amplitude. You're reducing the amplitude of the echoes and increasing the amplitude of the echoes. It's just an adjustment of that is on your monitor to increase or reduce the amplitude of the echo. Then the other thing you asked was the calcification of the retinoblastoma. Are you still there?
Yes.
Yes, ma'am.
Yes, okay. So typically, that's why you need to have clinical correlation. But you will see the mass-like lesion coming from the retina, okay? And then you will look at the corresponding A spike. Look at the echographic interface. Look at the A scan spike. Do you have some areas that have very high spikes? First of all, if you look at the texture of the echo texture of the mass, you will see that there are some areas that will be very hyperechoic, extremely very bright. And if you look at the A-scan spike over that area, you will notice that it is very bright. So some areas may not have very high A-scan spikes still in that mass, but you'll see some areas that have very high spikes. So the mass may somewhat be echogenous in its echographic interface. So of course you cannot categorically say if it is calcific. But you know, with your understanding of retinoblastoma, that if you're seeing these very high spikes and a very hyperechoic mass, then that's likely to be the calcification from the retinoblastoma. So it's only if you take it to histology that you can, be very sure that you're dealing with calcification. But this is just supposed to, points to the fact that you're likely dealing with such a lesion based on the amplitude of your A scan spike and the texture, the echo texture, where you see the very hyperechoic, extremely hyperechoic dot lesions in the mass itself. Does that answer your question?
Yes, ma'am. Thank you.
Okay.
Before I go to the next person's hand that is up, I would like to take some questions from the comment section. One of the questions here says, Ma, what of when you have combined retinal and choroidal detachments?
Okay, yes, you can. Yes, you can have it, and you will see. That's why you have to scan in different orientations. So you will definitely see your dome-shaped mass, and you will definitely see another membranous opacity. So you have two types of membranous opacities that you're seeing. You will see the membranous opacity that is attached to, because you can have 2 or 3 or even 4 pathologies in one scan. So you will see your membranous opacity with a high spike, with very restricted movement attached to the optic disc. And you will also see your dome-shaped membranous opacity coming from the periphery. And you will know that there's more than one pathology here. So for the retinal detachments, so what you'll be doing is, what you'll be looking out for, or what you will see 2 membranes. So you want to know if is the same, if they have the same characteristic or they have different characteristic. You want to know, am I dealing with one pathology or 2 different pathologies here? So you can have more than 1 or 2 or 3 pathologies in the same patient. So your retinal detachment, the membranous opacity will be attached to the optic nerve. Very high spike, very limited movement. Your dome-shaped choroidal, your dome-shaped membrane points to a choroidal detachment. Does that answer the person? Yeah, go ahead.
Okay, sorry. The next question here in the chat box says, I want to ask if there are any limitations or challenges associated with interpreting B-scan images of the posterior segments.
Any limitations or challenges?
Yes. Associated with interpreting B-scan images of the posterior segments.
Like everything, there will be challenges and what did he ask? Yeah, there will be challenges in a nutshell. Yes. One of the challenges that we see, and I'm sure you experience in your where you work, if you're working in a government facility like we do, is the radiographers that do the ultrasonography, and they do not have the standardized echography. They don't have the A-scan component. That's one. So when they send it to you, that A-scan component is not there. So you cannot interpret what you're seeing on the B-scan. You can't tell if the lesion has a high spike or a low spike, or the amplitude of the spike. You can't tell. Secondly, the probe that they use is abdominal probe. Is an abdominal probe with a frequency of about 4 megahertz, and the resolution is very poor. So a lot of the times we see them reporting vitreous hemorrhage. And if you're not careful, you can go and give a patient anti-VEGF because you think the patient has vitreous hemorrhage. But meanwhile, when you use the right ocular, the right frequency of probe, with a better resolution, you will see that there's nothing in the vitreous. So those are some of the challenges that one may have.
Thank you very much.
If you have multiple pathology, you, like the other person asked, you may have those challenges as well, but clinical information will help you in that scenario.
Thank you very much, ma'am. We have another hand up. Dr. Ubedu, please unmute your mic and ask your question.
Yeah, thank you very much, Professor Fibai, for the wonderful lecture. Further to the challenges, somebody asked about challenges about scanning. One of the problems, especially if you are practicing in a public institution, like you said, the radiologists are the ones doing the scan. And recently we found out that they don't even bring the pictures. But even the pictures is better advised that when you are doing a deep scan, that you see it live, and that the kinetic motions are very important. So I would suggest that before every department of ophthalmology to have at least a B-scan machine, so that at least residents can have a first-hand knowledge of what you are doing. And even in some institutions that they have, the residents are not the ones doing it. Maybe some other person is doing the scan. This is also very important in doing cataract surgery. If you can't see the depth, like most cataract that we have, you must ensure that a deep scan is done. Because hiding behind the cataract, you have maybe vitreous hemorrhage, or even retinal detachment or other pathologies. You do a beautiful cataract surgery, and the next day the patient is not seeing. And you wouldn't know whether you are the one that induced the RD or it was pre-existing before. So I will, maybe from the college aspect, ensure that every department, everywhere there is training center or even not, they must have a B-scan to at least get familiar. It's a very wonderful lecture, and some other gray areas. You really tidied it up for us, and we are better equipped now to interpret some of the things where we're scanning. Thank you very much.
Thank you very much, Dr. Obedo, for your comments. Honestly, I always recommend that as much as possible, every ophthalmologist should do their own scan. You should have a scanning machine right there, just like you have your slit lamp in your consulting room. You should have your B-scan right beside you. So you see the patient clinically, you finish your slit lamp examination and all that, and then you scan and get all the information you need and start your treatment immediately, rather than send the patient to go and have a scan and come back the following day or the following week, and all that. So as much as possible, if it's possible, let every ophthalmologist do their own scan right there, just like doing the fundoscopy right there in the clinic, because what the echographer will give you may not even be what you want. The echographer cannot possibly print out every echogram. And that's why it's also important that you give the echographer the right information. Do you want them to focus on the left eye? Though both eyes must be scanned, but the study eye will be focused on, so that the person is giving you the important information. For instance, hyperechoic scans seen in this mass lesion, that will tell you immediately, oh, so what I saw was actually a melanoma, or what I saw was, the choroidal detachment and all that. So the information that you also give the echographer, if you're not doing it, is also important. It helps to tie up the findings. But it's important that, as much as possible, just like you have your fundoscope, your ophthalmoscope, and your slit lamp, you should actually also have your B-scan, right beside you.
Thank you very much. Do we have any more questions? We're trying to bring this session to a close now. Are there any more questions? We've posted the link to the CPD forms on the chat box. Please use the link to access the form, fill it, and kindly return the form back via email to academy@eyefoundationhospital.com. Any more questions, comments? Okay, in the absence of no comments or questions, I would like to thank Professor Febai Bassi for this very insightful, wonderful lecture and for taking the time to honor our invitation at the Kunle Hassan Eye Foundation Academy. I'd like to thank everyone who took out time to join us for this lecture. The Kunle Hassan Eye Foundation Academy Retina Lecture Series happens once every month. So first Wednesdays of every month, we'll be communicating the subsequent lectures coming up to everyone. So thank you so much for joining. Thank you very much. Thank you, Professor Bassi. Thank you.
Thank you, Frances, and thank you, the Academy, for having me. Thank you, everyone who has taken out time to also attend this lecture series. Your comments and questions were very welcome and appreciated. So have a lovely day, everyone.
Thank you.